Ladies and gentlemen, esteemed colleagues, honoured guests, friends and family, my name's Dr. Vicky Halliwell and I'm the Deputy Dean in the School of Health and Society, and it's my great pleasure to introduce Professor Yeliz Prior, a distinguished alumni of the University of Salford and an acclaimed leader in the field of rheumatic and musculoskeletal conditions. Yeliz's journey is testament to her unwavering commitment to transforming lives through research and innovation. Her lived experience of rheumatic conditions from a young age fueled her drive to become a health professional and work in rheumatology. Starting her journey as an occupational therapist right here at the University of Salford, where I had the pleasure of being one of her lecturers, and she made her mark, and we knew then she was destined for great things, she openly shared her academic challenges as a non-native English speaker. However, not only did she conquer these hurdles, but she also excelled, culminating in the completion of a PhD at the School of Medicine at Keele University. Following this, she returned to Salford 12 years ago as a full-time researcher, during which time she also continued to work clinically in the NHS. Since then, she's established herself as a widely published author, contributing to academic textbooks, high-impact scientific papers, and held external leadership roles in professional organisations, patient charities, nationally and internationally. What makes her work truly remarkable is not just the depth of her research, but also the breadth of her contributions. From clinical practice to research and education, she's helped raise the health professional profile across the UK in policy meetings, as well as on international platforms. Over the past 5 years, she's played a pivotal role as the programme lead for the EPSRC Centre for Doctoral Training in Prosthetics and Orthotics, a flagship programme for our university. Her dedication extends beyond this role, and she actively contributes to teaching across various programmes and provides supervision for research students. Thus, she's instrumental in shaping the next generation of health professionals and researchers at Salford. Today, she will present her inaugural lecture titled Remote Possibilities in Rheumatology, Innovations for Self-Management and Beyond. This will delve into her innovative research, particularly her collaborations with industry, patient and public involvement and engagement to pioneer digital therapeutics aimed at empowering individuals to manage long-term conditions effectively. It is my absolute pleasure to welcome Professor Yeliz Prior.
Very much, Vicky. That's amazing to hear from my lecturer. I always had a lot of respect for. Some of my lectures are here actually from when I was a student, and a lot of people that's actually been really important in my career. So yeah, so I've forgotten everything I was going to say. You have to bear with me now. Let's start. So I'm going to start with a bit of an overview of the field first about rheumatology and musculoskeletal diseases. And because it's only a sort of 40 minutes lecture, I'm going to specifically focus on the digital therapeutics that we are developing here at Salford, give you a bit of information about where I come from, how my clinical and academic journey, and also teaching and learning. So there will be some questions and answers at the end for you as well. I want to start with a question. How many of you here have musculoskeletal conditions or joint pain? Just put your hand up, yeah? Yeah, so quite a few of you. Actually, over 10 million people in the UK have arthritis. So arthritis is a much more known term for musculoskeletal conditions. And when we talk about these 10 million people, they're mostly osteoarthritis, which is the most common form of arthritis. But there's also less common forms of arthritis, such as autoimmune diseases and rheumatoid arthritis, psoriatic arthritis and axial spondyloarthritis. But just because they are not common, it doesn't mean that their impact is not far-reaching. So if you put into perspective, is 1 in 6 people, have issues with pain and stiffness in the UK. So that's a lot. So I've already talked to you about the kind of the problem, and it's not just the pain and living with fatigue and activity limitations. Arthritis also affects things like work participation, And so the pain and limitations you experience day-to-day activities affects all your life, really. And as an occupational therapist, we are mostly concerned with this impact of arthritis in people's daily lives and work lives and leisure lives. So yeah, I'm particularly interested in work because I'll go into it more later, that we are part of the Center for Versatile Arthritis and Medical Research Council for Musculoskeletal and Health and Work in the UK. And in terms of arthritis and work, we know that people from socially deprived areas and some ethnicity groups, minority ethnicity groups, are even more disproportionately affected. So if you can have a look at the charts there, which I can't see, I actually left my glass at home today, of all days. You can see that it's much higher in populations like people from Pakistan and Bangladesh. And of course, when you're living in the deprived areas, your access to healthcare and other services to get more help with work, things like work, is also more difficult. So I'm a rheumatology occupational therapist, a very proud one, and we are not a big group in the UK, but actually bigger than some of the European countries in terms of specialty as a rheumatology occupational therapist. And the occupational therapist input is mainly about looking after people to help them to do the things that they want to do in daily life. So that goes from things like self-care. It could be washing and dressing, very simple things, to sexual health and well-being, to work and leisure. So it's very wide-ranging, and it could be the relationships at work. So we do things like pain management, fatigue management, psychological mood management at work, and a lot of upper limb and hand therapy as well. So I've been at Salford working with a lot of podiatrists. Some of you are here. So I'm also a lot more into foot than hands these days, because we do kind of have a bit of both. But in OT, we tend to focus very much onto hand and upper limb. So a bit about myself, embarrassing pictures of that. So that's me. So I was born in Istanbul, Turkey, in late 70s as a fourth child in a family, a small family actually. And I was diagnosed with juvenile form of idiopathic arthritis at the age of 7. And I had the symptoms a lot earlier. The medical care in Turkey is not great, so we didn't have the national health system as we do in the UK, so I didn't really have access to best care. So my experience of sort of hospitals, I had it was quite a scary time for me, because I was hospitalized. I stayed in hospitals, and up until my early 20s, I couldn't even go into the pharmacy because the smell of medication used to make me scared. So I never thought I would be a healthcare professional. I actually wanted to be a journalist, which wasn't a good idea in place the Turkey, the political turmoil that we lived in. It hasn't changed much since. So instead, I worked in IT because I loved technical stuff and fixing things and supporting people. And through my job in IT, I started to work for a British company, Lloyd's Register of Shipping, which then helped me to immigrate to the UK at the age of 22. So that was a big turning point in my life. And well, shortly after age 25, I was already a mother of 2. Maximilian, who were sitting here in their 20s now. They were both taller than me by the time they were 9. So that's from the English side. And throughout sort of my journey of being a mother, my maternal care, I just loved NHS. The midwives were amazing caring for me. I actually thought, well, maybe I want to be a midwife. Well, till I had a sort of shadow one day, and I thought, well, not really. I can't really deal with blood. So I hold babies, but that's, yeah, doesn't qualify. So then I didn't know about occupational therapy, because in Turkey, we didn't have occupational therapy as yet. I looked at different careers, and occupational therapy, I had a shadowing day. And I really enjoyed it. I thought this is everything I wanted to do, because from a young age, I struggled with activity limitations and doing the things I wanted to do. And being me, I wanted to do a lot of things. But I was very isolated. And the idea that actually occupational therapists can help people to do the things that they can do, it's really appealed to me. So then I was very lucky to be accepted at the University of Salford as a mature student. My English wasn't that great, as Vicky said. Academically, I really struggled at first. But I managed to graduate with a 2-1 in 2008, the best class of 2008. I was really happy. And I even dared to apply for a PhD studentship, with my academic skills. Because I thought, you know what, so if I apply, if I don't get it, what the worst can happen? So because the PhD studentship advertised at Kiel University at the time, which I saw in the newspaper because that's where we saw things those days, job adverts, was very much occupational therapy. It was looking at self-care restrictions in older people with joint pain. So I kind of didn't pay attention to the epidemiological bits because I had no background in statistics or epidemiology. I didn't really know what it meant, to be honest. But I thought, I'll go and have a word with Ross, who's sitting here today. I first called him on the telephone, and he's from Glasgow. I couldn't understand anything he was saying. So I thought, can I come and see you in person? Which was actually a good idea to go and see him. But then actually I went to do a presentation in my interview, my stick wouldn't work. And Zoe, who is here from IT actually, I remember seeing her arm, so took my stick first and fixed it for me to do my presentation. So I didn't just work with amazing people like Ross, George, Dr. Roger Beach. Unfortunately, he's not with us anymore. He passed away, but he left a big mark on me. He was an empathetic ear throughout my PhD. Because it was a very steep learning curve for me to do a PhD. But I made a lot of good friends. I bagged myself a husband, which was a fellow PhD student. This is what happens when you spend too much time at work. So we got married between the thesis submission and the Bible, same time. But when you know, so. And then I came back to Salford, my home, to work with Professor Alison Hammond, who is the leading occupational therapy researcher in rheumatology. So I came as a research assistant 12 years ago to work in a project with work in inflammatory arthritis work rehabilitation, which I was really passionate about. And from that, I met all these influential people that I got to work with. So it's really opened doors for me. And I still work with all of these people today. And of course, this is a difficult journey, research day to day. I have a lot of mentorship supports because friends are everything. So those are the people who are also here. I'm really happy to see them. They just kind of carried me on. When I put them together, I didn't realize it was like a multidisciplinary team. It's very much like a rheumatology team, actually. But it was not conscious. So I become an occupational therapist to really work in the NHS, and I just kind of gone from BSc to PhD. I love research, but I really yearn to be also in the NHS. And we work in rheumatology very closely with our Northwest colleagues, and Nikki, who's also here. So she told me, oh, so-and-so is going to maternity leave. Do you want to do some part-time hours? And then I started to do 1 day a week part-time on top of my full-time. And then they decided to keep me when Helen came back from maternity leave. So that was the next 7-8 years that I was there. I worked with an amazing rheumatology team. And there are just a few of them here. So Nikki, who was there for 30 years, the therapy manager, she was more like my at-work mom as well. Very, very supportive, and I learned a lot from her clinically. I can never do a sprint like her, but I still watch the video every now and then just to remind myself. And Angela also worked as an occupational therapy advisor on many of our randomized clinical trials. And Joanne, who's also here, comes as a visiting lecturer at Salford to teach our students upper limb rehabilitation in the CDT, which stands for doctoral training, which I'll talk to you about in a minute. So So the external leadership, it sounds all grand, but it's actually really all came very naturally because in rheumatology, we work really closely with professional organizations such as British Society for Rheumatology. EULAR is European Associations of Rheumatology. They changed the name, it was European League Against Rheumatology, but now is, yeah, I can never remember what that just stands for. I can't read from here. But I was at the scientific committee of EULAR. I worked in many task forces with people from 40 different countries. So it's a huge rheumatology organization, and also with RCOT. So for example, at the moment, I'm chairing a rheumatology competencies and capabilities framework that is with BSR and RCOT together. So these organizations also work together. I put these pictures together because people always say to me, the research is a bit boring, you know, kind of just sit on the desk. It's a lot of fun. So I had a lot of fun doing it. I traveled a lot around the world. I have friends everywhere now, from Europe to Africa to America. So I can go anywhere in the world now, have a house to stay. And there's this mentorship programs as well. So I was helped a lot, as I showed you, those people who were my mentors and influencers. And I also like to pay back, so through the mentorship schemes, because it's always, we have this workforce capacity issue in rheumatology. So every time I meet a health professional, I'm always trying to get them into rheumatology to come and work with us. So as well as working with these professional organizations, patient organizations such as Versus Arthritis is practically funded most of my career and part of my also studentship and PhD students. It's fantastic for rheumatology because they offer programs like Nurse and Allied Health Professional Internship Program. So so Janice sits in there. So she was a Salford graduate as well, who was a podiatry. She came straight to do a PhD, and this internship program kind of warmed her up to do a PhD because it is a bit difficult to walk into a PhD straight from a degree. And Sally as well, now just starting at our CDT as a PhD student, was one of our interns. And you can see here, Amy and Lara also did really well getting postdoctoral positions, doctoral and postdoctoral positions. So NASS, National Axial Spondyloarthritis Society, is very close to my heart because I have axial SPA, and it took quite a long time, over 10 years, for me to get a diagnosis, even when I worked in rheumatology and I knew everybody. So a lot of people live with pain and limitation for a long time, especially if you're a woman, because it's more common in men. The diagnostic delay is huge. So we did a lot of work with them, with the policies and parliamentary meetings to bring attention to this issue about the diagnostic delay. And actually earlier this year, we were successful getting a NHR program grant, which will start in January 2024 for 6 years to look at this redesigning the diagnostic pathways for axial spondyloarthritis. So charities are amazing doing work like that. So I'm going to talk a little bit about the current projects. I'm only going to focus on mostly our digital therapeutics. So this is our clinical rehabilitation research team. It's within the Center for Human Movement and Rehabilitation, which is led by Professor Steve Pierce here. So there's only a handful of us in the group, but actually we do pool our weight a lot in projects, and we work with a lot of external people as well. And we have a patient partner, Andy Lavender, who supports us via several projects and working with our KPI groups leading this. So digital health was always kind of natural to me because I came from an IT background. So when me and Christina, our head of digital health, met, we were just like, yeah, God, we got so much ideas. Haven't got time or money, but we had lots of ideas. So earlier this year, actually, we published a book about digital health, and I've learned a lot from Kristen about digital health methodologies, because it's becoming more and more sort of important in health research to use these methods as we digitize care. So in terms of what we do in our digital health programs, we base our programs around three main areas. So it's about prevention. So you can see the cycle of change, the behavior cycle there. People are in different stages. You know, some people they might have a problem, or they are not quite ready to change. Some people actually really want to change, but they don't know how to help themselves. Some people have made some changes, looking after their long-term conditions, but can't keep up. And someone living with long-term condition myself, I know that it's really difficult. You know, life gets into your way, and you can't always get. So our digital interventions are kind of meeting those needs for both prevention, intervention to allow self-management. So we do that working around the combi model, which we talk about capability, opportunity, and motivation. So as researchers, we are here to support both people living with long-term conditions such as rheumatic conditions, but also things like diabetes that we work with, stroke survivors, to develop the capacity to help themselves. And we provide them with the opportunity, so making the information more accessible to them and more understandable in bite sizes. And we also use things like motivational interviewing and health promotion to engage these communities with our platforms to use, because you could create the best digital health interventions. If nobody is using them, they're not good. So the key to secret, which is not really, it is an open secret really, is working with patient and public. To me, it's really clear they're the end users. They're the ones, so we start with them, and there are only a few of them here that I had pictures to display, but they've been influential on most of our work, and from the idea to design to the delivery of the digital interventions. And of course, the social communities as well. So I'm quite active on things like Twitter and LinkedIn, mostly to connect with people from the same areas. And I keep thinking sometimes, oh, I might come out of social media, because you see someone say every things, but then again, I'll make some really important connection. So for example, the other day was World Arthritis Day, and I tweeted, and I met another occupational therapy student who had a GIA like me. And now we have a meeting next week because she wants to do a PhD. So things like that happens in social media. And the communities of practice. So we develop ideas with our patient-public involvement and engagement. We then go to the communities of practice and take their pulse as to what they think it needs to be done. We also work with industry. So Amprison and Limited, for example, I worked with them to develop my arthritis app, which over 5,000 people use in the UK now. So we developed online self-management programs. People can help themselves with day-to-day activities, with maybe mood management, physical activities, and work problems as well. So these are my babies now. The MSK Hub first came to around 2018. It was originally funded by a very small grant by Low Risk Trust. And it was by the time that we come up with my patient and public group, there wasn't anything like that out there. So there's loads now. But of course, things in research works a lot slower than when you work in the business world, because we have to get the money, we have to get sort of data protection agreements. So we had the first version of MSK Hub in 2018, which was actually used by 18 NHS Trust referred patients during COVID for our fibromyalgia self-management program. because during COVID, rheumatology departments had to put all chronic pain patients on the back burner to treat patients with autoimmune disease as a priority. So then we had lots of referrals to the website, people using it. But we also get a lot of feedback as to what was working, what could be better. So then last year, for over a year now, MSK Hub has been down, and we've been working on the version 2. And it's much improved version. It's not launched yet, but I'm going to give you a bit of a sneak preview.
Musculoskeletal conditions and symptoms such as joint pain are common, particularly in those 45 years and older. Advances in health and science have increased our life expectancy, so we live longer than previous generations. Due to an aging population, we anticipate that musculoskeletal conditions will be even more prevalent in the future. A common challenge for those living with musculoskeletal conditions is knowing how to manage their symptoms to ensure they can carry out activities such as work and leisure without interruptions to their daily lives. MSK Hub is an online self-management platform sponsored by the University of Salford. It was collaboratively developed by health professionals, researchers, and individuals with musculoskeletal conditions. It provides users with access to self-assessment tools and personalized solutions designed to help them effectively manage their symptoms. The platform also enables users to track their activities and participation in daily life, including work and leisure over time, providing tangible measures of their health and overall functionality. The MSK Hub is free and accessible to everyone, allowing users to create their own detailed online musculoskeletal health record, which is accessible as and when needed to aid clinical consultations and support the progress of a self-management program. Purpose-built to offer support, the Hub unlocks relevant health information and delivers it in a way that is accessible and easy to understand. MSK Hub also serves as an ongoing database for research. The information we gather will inform future studies into musculoskeletal conditions. This helps grow the knowledge base on effective advice, solutions, and interventions. The platform's widespread accessibility ensures that the evidence collected will represent a more diverse population, reflecting a broader range of experiences and perspectives.
I was so excited when I got that evaluation. It's really exciting creating and designing, working with actually amongst us today, the talented people who design these animations in the program. So it's all custom made for MSK Hub. It's very exciting. So previously in the first version of the MSK Hub, it was very much occupational therapy based. So we had activities of daily living, upper limb and psychological health management. The feedback was, well, what about the feet? What about the hip? What about my knees? So now we have added that as well. So people will be able to access to valid, rigorous self-assessment tools to be able to collect this and save on their dashboard, share with their health professionals, and also then signpost it to help them how they can help themselves. So that's MSK Hub is about activities of daily living, symptom management, and self-management. So I also mentioned that arthritis affects work participation. So work is really important to all of us. I know how important to me. So I spend more time at work than with my family. They know that. And people with arthritis are less likely to actually be at work. 20% less likely to be at work than people without arthritis. People with rheumatoid arthritis within the first 5 years of diagnosis are, more likely to lose their job, so become work disabled. So at Salford, we are part of the Center for Musculoskeletal Health and Work, which is a center encompasses 7 universities, as you can see there, led by Professor Gary McFarlane, our maiden, wonderful center manager, Stuart Anderson, who sort of coordinate all our work. So one of our projects within this center was Work Well. So Work Well is, so the Work Well digital is about keeping people working. The people are already at work, living with arthritis, to keep their job, because we know it's easier to actually help people when they're at work then when they become work disabled, they're much less likely to come back to work. So we have conducted a large randomized clinical trial across 18 NHS trusts in the UK with an aim to look at basically whether a occupational therapy-led work rehabilitation program can help people to stay at work. And also we wanted to see whether it was cost effective. Alongside of this, we did a process evaluation where we also did the qualitative elements, interviewed 40 participants from both the control group and the group that received the work rehabilitation. So both people in the control group and in the work rehabilitation group also received this self-help advice pack. And what we found when we're doing qualitative interviews, that people were actually in the control group were using the self-help a lot more than they did when we did the feasibility trial about 8 years ago, because we didn't have as many digital platforms then. So people are much more keen to help themselves. And a lot of people said, I wish there was a digital platform that had all this information there, that I don't have to go to different places. And then I wish I could personalize it. So I wish it could answer my own specific questions. So we decided to digitize WorkWell, funded by Versus Arthritis, to meet that unmet need. And I'll introduce you to the sneak preview now.
Balancing work and home life with inflammatory arthritis is challenging, especially when managing chronic pain, fatigue, and activity limitations. If not able to access support at work, people with arthritis are much more likely to leave their jobs and face challenges in returning to the workforce in the future. A preventative approach where work support is put in place before the work starting to impact health and vice versa mitigates the risk of future job loss, leading to more positive health and work outcomes for the individuals with arthritis and the society as a whole. WorkWell is a free online work solutions program funded by Versus Arthritis and sponsored by the University of Salford, designed to support people with inflammatory arthritis stay in employment. This is a digitized version of a clinical job retention work rehabilitation program based on extensive research into work and arthritis, developed in collaboration with digital learning specialists and patient and public involvement and engagement. You can visit and access the WorkWell solutions without a need to register. If you want to access personalized work solutions, you will need to register with WorkWell, as we will need some information from you to tailor the work advice. The guidance and solutions for work-related issues will be stored on your dedicated dashboard, providing convenient access. Living with arthritis while juggling work and home life is undoubtedly challenging. WorkWell Digital is here to make it easier by providing personalized work solutions and resources tailored to your needs. If you are struggling at work, visit WorkWell Digital for more information.
I'm struggling at work. I think I will visit WorkWell Digital. So when you visit WorkWell Digital, what you're going to find? So actually, not just people with arthritis, but anybody can probably find this. Will find this resources very helpful, including NHS therapists who is delivering work rehabilitation. So we have the manual, which is a digital manual. You can do a word search, or you can go to sections to find helpful guides, which are all written in lay language to help people. So if you register, then you have to complete a couple of assessments, which is the Rheumatoid Arthritis Working Stability Scale, which will tell you whether you have any difficulties at work, you have work instability. Then you can complete the assessments we used with occupational therapists called WESRC, Work Experience Survey in Rheumatic Conditions. That will tell you exactly in which areas of work that you need help. And then it will actually design you a program that is specifically for your needs. It will signpost you to those information that you need. There's also, so with this information, there's also self-management program that you can undertake, which gives you different scenarios and what you will do in that situation. So it's an interactive program to learn. So how to write a letter, for example, to your employer if you struggle at work to ask for work accommodations. And it gives you feedback. So this is the company I work for, well known, some of them here. It's been absolutely amazing working with it. It's so creative. So yeah, thank you so much, guys, for all your help with everything. And the Gasmark 8 as well, who hosted the websites and did all the technical work on the background. So to finish it off, in terms of all these things we're doing, it's important to transfer this knowledge to other fields, because people with musculoskeletal conditions tend to have other long-term conditions and vice versa. So what we learn in this field, we then look into moving to other fields. So one of my PhD students, Nazamin, is created this Stroke Survivors Hub, which she actually used the evaluation of daily activities with stroke survivors to adapt to the stroke context to create a acceptable and usable website to help people with stroke. We have a dementia support program, Empowered Conversations, which is an online program to support people who are caring for relatives or significant others with dementia, because it can be quite a lot emotional and physical load to care, and they don't really have always people to talk with. So it's an online program to put people together to actually talk about how to support people with dementia. Another program we have is looking at diabetic foot ulcer prevention, which is led by Dr. Dan Parker in Salford, and it's Professor Luigi in Southampton, who is the CI, is looking at developing a technology to prevent diabetic foot ulcers. Is a sensor technology basically, and I'm helping to work with the patient public involvement and to develop a health behavior up to support the use of this technology. And this is our Center for Doctoral Training, Prosthetics and Orthotics, because of course all this learning is also need to transfer to our students and teaching. And this is, as Vicky said, our flagship program is we are on the 5th and last cohort this year, and we just had our first graduates. And yes, so some of the occupational therapists are working with rheumatology teachers in this program. We have a very multidisciplinary people helping to basically create a new generation of prosthetics and orthotics researchers. So some of the students are from engineering, some of them from biomedical sciences, some of them occupational therapists. It's very, very good mixture of students. So future. Now I can't read that, so I have no idea what the future holds. Well, basically, it's keep doing what we're doing in the future and working with professional organizations, with public and patient involvement and engagement, continue to digitize care, evaluate care, and look into implementation, the problems with upskilling health professionals and supporting self-management of long-term conditions. So watch this space, because you know, in research and academia, I love this. Doesn't always go as we plan. Thank you.
Thank you very much, Liz. That was a fantastic presentation. And I loved all those photos about all the people that you've connected with and worked with. And it just shows how collaborative you are and what influence and reach you've had across the world. And that, I just thought that was stunning. So we've got time for questions. We've got a couple from our audience online, which I will ask you, and then we'll probably have time for 2 or 3 in the room. So get thinking, and I'll ask for hands up in a minute. So the first one is, you are collecting a lot of personal data online. How do you ensure this is kept secure and confidential?
Very good question. And yes, so I had to complete about 120 pages of data protection impact assessment at university, because we have very stringent systems at university to ensure personal data is safe. So we have to have a legal reason to have that data. So we can't just say we want it because we want to do research. We have to justify everything that we, every data we're collecting when it's personal data. So people who are using the platform can be self-assured their data is secure, and they can also, they have rights as subjects, data subjects, to submit and request at any time the data we are holding about them. And most of them is anonymized and confident, sort of kept confidentially in very secure service.
Thank you. Thank you. So another one, a great question. What top tips would you give an occupational therapist who wants to get into research but has only worked in the NHS in a clinical role thus far? How do you take the first steps?
First of all, I would say only worked in the NHS is just the benefits. You know, that's brilliant. You have all this clinical knowledge to bring to research, and we need you. We need people with clinical knowledge to come into research. I'll say just take the first step and get involved in research by taking part in sort of recruitment, maybe in smaller steps, and see how you feel. And then, you know, feel free to approach me as well, and we can talk about, you know, how we can help you to get into research.
Brilliant. Thank you. Okay, questions from the room. Yes.
The great lecture, Yeliz. Thank you ever so much. The future clearly moving to be more digital. How do you prevent that widening inequalities in society?
I'm just going to repeat that question so that people online can hear it. So the future is becoming more digital. Read the next sentence.
How do you stop that increasing inequality in society?
How do you stop that increasing inequalities in society? Thank you.
Absolutely. So we all tend to presume everybody have access to digital information, everybody have digital literacy and digital health literacy, and also the equipment or the internet connection. So this is the point of working with creation, public involvement, engagement. So we tend to work with local communities and people from more deprived areas, the ethnic minorities, to see how we can tackle this information, tackle this problem. So future is digital. NHS going digital. We are, since COVID, we have more and more online consultations. But yes, it's a problem that we have, that not everybody have access to it. I don't have a quick answer to but we try to actually get those communities involved to upskill them, and also get the University of Salford is really great. Actually, we get a lot of internal funded streams to buy equipment and support those people to access these platforms as well. Yes.
Project. What's the potential for this or damaging? So a few people say something we presented, it's got applicability to certainly in general, but possibly beyond that. So do you have any plans to extend it to other conditions?
Yes, we do.
Sorry, Yeliz. I'll just paraphrase that. I am going to paraphrase that question. So it's about work well and the potential and the possibilities for going beyond the current scope.
Yes, so current scope of work well digital is for people with inflammatory conditions such as rheumatoid arthritis, psoriatic arthritis, and inflammatory forms of arthritis. But we also working within the Center for Work and Health, who also develop other digital platforms such as Pain at Work, which is looking at chronic pain. So it could be you don't have to have a diagnosis, and it doesn't have to be musculoskeletal, and other problems that you can have at work. So we applied to NHR Work and Health stream, and we were able to get a development grant. So to work in the next year to see how we can bring those platforms together and make it more available to wider long-term conditions. But as you say, most of the things that the advice we give, like rights at work, you know, how you can talk to your request, job accommodations and things like that, is very much translatable to any long-term conditions as well.
Great, thank you. We might have time for one final question. Yes, Bethan?
What do you think the future of occupational therapy research is?
Okay, so that's a big question. So where do you think the future of occupational therapy research should go? No pressure.
So I don't think I'm qualified to sort of think about whole occupational therapy research, but I'm kind of more focused on rheumatology occupational therapy, I suppose. And we are quite small but mighty group in multidisciplinary teams in rheumatology. And we're so busy at clinics. As all occupational therapists know, in the UK and we work in rheumatology, I know probably 90% of them do get involved with research as well. So I think we need to get more clinical OTs into research to actually get that kind of evidence base in, so we can support the business plans to get more OTs into clinics to show that actually what difference they will make to people's lives. Does that answer your question?
Thank you. So I would really like to thank you, Yeliz, for such an engaging inaugural lecture. Thank you for joining us, and those on Teams, thank you very much for joining us. Can we give Yeliz a great big round of applause?